our discussion regarding impending and pathological fractures. So as an orthopedic surgeon, my aim is number 1, to aid in diagnosis of bony metastatic disease. Number 2, decision in making regarding operative and non-operative intervention. Number 3, recognize disease-specific considerations. And number 4, perform fixation or reconstruction. Regarding primary tumors, it can be metastatized. They can be breast, prostate, lung, kidney, thyroid, and gastrointestinal. Others can be lymphoma, leukemia, and myelomas. Skeletal related event can be pathological fracture, surgery for a bone lesion needing fixation, radiation of symptomatic lesion, or spinal cord compression fracture due to a lesion. Regarding the symptomatic workup, we need to have detailed history regarding pain, mostly these patients are more than 8 years of age, must rule out that the lesion is not a primary bone sarcoma because treatment paradigm usually necessitates wide resection instead of fixation or treating the fracture itself. For the goal of workup, the goal is to determine the primary site of malignancy. For the metastatic workup, it is important to take a history and physical examination, lab investigation like CBC and differentials for lymphoma, metabolic panel along with ESR CRP to exclude infections, and alkaline phosphatase and serum protein electrophoresis for myeloma. A radiograph of the entire bone should be done. An MRI with or without contrast. This was not included in the Rograph original study, but it helps define the bone marrow and soft tissue involvement and can plan accordingly. And CT scan of the chest, abdomen, and pelvis to exclude the lung, kidney, and breast and prostate lesions, and a bone scan. And at the fourth stage, it should be bone biopsy. This was a study conducted by Rograph in 1993, which has showed 85% of the cases you will able to identify the primary tumor and could treat or plan accordingly. The bone scan information helps to target your biopsy site and help with the surgical decision making, whether white cell metastasis versus solitary metastasis. When you're taking a biopsy, a sample should be sent in permanent pathology. For permanent pathology, it should be sent in formalin. Number 2, a fresh pathology should not be sent in formalin and allow for histochemical analysis for lymphoma. And gram stain culture is always advisable. If there is any possibility with the histological analysis that biopsy shows sarcoma changes, do not proceed with planned fixation and reconstruction and await till final diagnosis. For deciding for a pathological fracture whether to operate or not to operate, there are 2 criteria. The first is Harrington criteria, which states that the lesion is more than 50% diameter, lesion is more than 2.5 centimeter, there is persistent pain following radiation, and lesser trochanter fracture or avulsion fracture. This classification accounts for the proximal femurs and does not account for the primary tumors. Other way is Meiral grading. A Meiral grading consists of site, size, pain, and lesion. A score more than 80 portends towards prophylactic fixation. May lead to small degree of over-treatment as false positive rate is about 6%. A third type of analysis is called CTRA, which is CT-based structural rigid analysis. CTRA has shown to have improved sensitivity and specificity when compared to both scoring system. It utilized CT scan to quantify degree of bony involvement as compared to the contralateral side or normal match controls. Regarding non-operative therapy, number one, chemotherapy or immunotherapy directed for the primary tumors, for example, in myeloma or lymphomas. Number two, bisphosphonates or denosumab. Number three is X-ray radiation therapy. Number four is percutaneous radiofrequency ablation or cryotherapy. For predicting a survival of a pathological fracture, there is a PathFX tool, which is called www.pathfx.org. It's an online-based system which allows for input of clinical and patient-specific variables and generates likelihood of survival of at several time points, may aid in decision making regarding extent of planned surgical intervention. Now, some of the specific metastatic tumors, metastatic lung carcinoma. So traditionally has poor prognosis but has improved in recent years. Uh, that that is the reason that there is some in some patient there is PD-1 mutation which can be treated by immunotherapy. Usually later appearing lesion and maybe cold on bone scan. Low propensity for a fracture sensitive to radiation. Frequently required adjuncts like polymethyl methacrylate fixation. Renal cell carcinoma, it's a resistant low sensitivity to radiation. It's a vascular tumor, so may need preoperative embolization. Some may consider wide resection and reconstruction of metastatic lesion in case of oligometastatic disease. That is only a few sites involved in the disease. Local tumor progression is rarely a possibility following intralesional excision. Regarding thyroid carcinoma, it metastasized to the bone, relatively good prognosis. They are sensitive to X-ray radiation. Vascular assessment and preoperative embolization is possible. Regarding breast carcinoma, these are tumor expressing hormone receptors, which are HER-2, HER-nu, and they can have medical treatment. Lesions usually are mixed or blastic in appearance and very sensitive to radiation therapy. Prostatic carcinoma are basically blastic in appearance and very radiosensitive. If performing intramedullary fixation, beware of blastic lesion that may be difficult to ream. Recannulate intramedullary canal with drill bits, reamers, and under fluoroscopy. Regarding whether to fix or reconstruct, we can go for fixation if there is number one, adequate bone stock. There is good bone healing or reconstruction possible, especially for breast, prostate, myeloma, and lymphomas, and non-periarticular location. A reconstruction is advised if there is inadequate bone stock, poor chance of bone healing, solid lesion with oligometastatic lesion, which resection can be planned, and periarticular location, then reconstruction is advised. In acetabular fractures, degree of bone loss may warrant revision style implants. It may be Harrington style reconstruction with rebars and cements. Utilize screws and pins, insert antegrade or retrograde in the periacelular defects, help to restore the continuity of the ileum, in the pubic segment, often require lateral window incision over the crest to insert pins. Good short-term results, however, long-term results are of intermediate or worse. There's Harrington-style reconstruction. Newer generation tantalum implants reconstruction can be used with the pins and screws.